Hi, everyone, and thank you for joining us for today's webinar. Could this be the one-two punch for weight loss success, GLP-1 medications, and comprehensive lifestyle intervention programming? I'm Marianne Murphy, Vice President here at the Medical Fitness Association. I'd like to take a brief moment to introduce our two presenters. Raina Childers-Richmond is a registered dietitian and certified health coach. She developed, facilitated, and managed outpatient adult, pre-surgical, adolescent nutrition, and weight loss service lines in 2 medically based fitness centers south of St. Louis, Missouri for 15 years, where she trained, mentored, and managed a team of registered dietitians, health coaches, and dietetic interns. Raina holds a Master's of Science degree in Human Nutrition from Southern Illinois University, Carbondale, and a Bachelor of Science in Dietetics from Southeast Missouri State University. Dr. Susan Boswell is a clinical coordinator and pharmacy resident program director at Southeast Health in Missouri. She has been with the hospital for the last 25 years. She is also an adjunct clinical instructor at the Drake University College of Pharmacy and Health Sciences. Susan has her Doctor of Pharmacy and BS in Pharmacy, both from the St. Louis College of Pharmacy. So today's webinar is brought to you by MFA Industry Partner Health One, your partners in weight management. Now, if you have any questions as we move through today's webinar, please go ahead and type them in the chat section or the Q&A section of your toolbar, and all questions will be answered at the end in the order they were received. So go ahead, Raina and Susan, take it away.
Great. Well, thank you so much, Marianne, for that introduction, and we're happy to be here today for sure. Susan and I are both naturally fast speakers, so we want to just share that if something is unclear because we've moved through it quickly, or if you'd like more information about something we've introduced, we do have our contact information at the end of the presentation. We've also provided a resource list for the resources we use to put together this presentation. And Susan has also added a abbreviation list there because she will reference abbreviations through several parts of her presentation as well. So little housekeeping there. But 2023 has been the year of the GLP-1 medication. Not that the drug is new, but certainly it has exploded this year. Susan and I do not have any conflicts of interest to disclose as we present to you today. Our objectives are to review the GLP-1 medications and their growing use nationwide, briefly describe some components of comprehensive lifestyle intervention programs, and discuss how medical fitness facilities can leverage their clinical expertise and resources to compete in a growing weight loss market. And again, the resources are at the end of our slide deck. Quick overview. Susan will give us the GLP-1 lowdown. I get what I did there, drug lowdown. Okay, well, I thought it was funny. Raina will discuss some programming considerations, and we'll wrap with an example and some questions. So I'm going to turn it over to Susan to get us started today.
Great. Good afternoon, everyone. It's my pleasure to be here today. So let's get started. So what is obesity? Obesity is a chronic, progressive, relapsing, and treatable multifactorial neurobehavioral disease. Back in 2013, the American Medical Association designated obesity as a chronic disease. So here we are, 2023, 10 years later, and I'm excited that we have made great strides in developing medications to treat obesity. And that will be my focus of today's presentation. This next slide basically depicts the obesity definition. So obesity involves genetics, social culture, immune, medical, endocrine, neurobehavior. And because obesity is a multifactorial disease and manifestations in individual patients, we have to individualize our treatment things. So one size does not fit all. So let's remember that as we move forward. This next slide, so what I have here under the weight management is that Raina referred you that we have some references at the end, and I have put a lot of the evidence-based guidelines there for you, especially the pediatric one that just came out earlier this year, and there was a lot of news coverage on that. So that'll be a good reference for you if you take care of pediatric patients. For today, we'll be focusing on the adult dosing for these patients. But weight management, so what they're saying is that still lifestyle manifestations remain the cornerstone of therapy. So you can have nutrition, physical activity, behavior, and then anti-obesity medications come in there and bariatric procedures. Of note, about 2% of people living with obesity are on evidence-based medicine, anti-obesity medicine. So there's a lot of room for us to improve on that. I think it's good too. It's taken off, as we can see, but I think there's a lot of room that people maybe who aren't getting it need to be on the medication. The other thing, because we're seeing such drastic weight loss with these new medications, that they actually may be just as effective in as how much weight you will lose when you compare it to bariatric procedures. So I think that's really good for us. Next slide, Marina. Okay, so this slide here basically took all those evidence-based guidelines, and what it does is it's just a classification of obesity, and you look at it based on the BMI and then our recommended therapy. So as you can see, for all of our classifications, healthy lifestyle is still the mainstay of therapy, no matter which class you are in. And then depending on if you have some weight-related comorbidities, diabetes, hypertension, then you would start an anti-obesity med. And then if you're down further class, higher BMI, you would start anti-obesity medicine right off the gate. However, some of you are probably familiar with, I told Raina, all my slides like change because everything in the seems to keep changing in this world when it comes to obesity, which is good. But back in June of 2023, the American Medical Association actually said the use of BMI alone is an imperfect measure because it doesn't directly assess the body fat on an individual level. So they also said, which I thought was of note and was really good, is that the use of BMI should not be the sole criterion to deny somebody appropriate insurance reimbursement. So I think that's really important too. But I think moving forward, we have all these evidence-based guidelines. They've all used this BMI. And I think I'm anxious to see in the future now how this new American Medical Association is going to change some of our evidence-based practice as we move forward. So I felt it was, pertinent to keep it in there today, but look for it to change in the future. Next slide, Raina. So what are these new agents I keep talking about? And Raina mentioned. So of course she mentioned, and she alluded to, the glucagon-like peptides, or the GLP-1 agonists, I may refer to them. In pharmacy world, we use a lot of abbreviations. It's our lingo. There's also a combination product, and that is called, that's a GLP-1, and it's in combination with a glucose-dependent insulin-tropic polypeptide, or a GIP. It's important to note that all these medications in this class were approved first to treat type 2 diabetes. And how they work is they delay gastric emptying and promote fullness in the stomach. And I will only talk about, there's a lot of GLP-1s in the class. I am only going to focus on those ones today that have the obesity indication, are currently being used for obesity. And so this won't be an all-inclusive list today. So let's get started on these wonder drugs. So here is how they work. So I have a big hamburger here and going to eat that juicy hamburger, and my blood sugars are going to go up. And so when your blood sugars go up, your small intestine normally releases these hormones, and these are these GLP-1s and GIPs. And when this happens, they increase insulin secretion by your pancreas and cause your liver to decrease glucose being produced. So we said these drugs were first approved for diabetes. So what happens in this case, your blood sugar goes up, your body normally responds by releasing these hormones. So the problem with these hormones are they're pretty short acting. They don't last long in your body. So the thought was, well, let's make some synthetic drugs that work just like this. So that's how they came up with these medications to work on this, and they last longer. So the question is, so we know how they work for diabetes. They increase insulin production and they decrease glucose production. But how do they work for obesity? And the thought, their thought is that they work in the gut. And so what they do is they slow the movement of food from the stomach to the small intestine. So these people feel fuller and it lasts longer. The other thing to know too, in your brain, as you can see, it works in your brain. It works in a lot of these receptors are all over your body. And in the brain, it tells you that you're full. Something else I want to kind of point out is, if you can look in your chart there, the heart and vessels, it is also showing some cardioprotection. And some of you may have just seen Wegovy just about 2 weeks ago. They are all over the news. We got the cardioprotection. So it may prevent people who have like heart disease. This might be good options in them because it could be cardioprotective, decreased stroke risk, decreased heart failure, decreased kidney disease. So the first drug that I'd like to talk about is liraglutide. So liraglutide is the generic name, and it comes in 2 brand names. One is Saxenda, and Saxenda is actually the anti-obesity medication. And Victoza was approved by the FDA for type 2 diabetes. The dosing on this medication is daily, and you do weekly titrations with these medications. Side effects are most common because I said it kind of works in the stomach. So the good thing to think about, the most common side effects you will see with these are vomiting, diarrhea, nausea. Rare side effects would be acute pancreatitis, and there have been some thought of thyroid C tumors. They first saw with these that the weight loss was about 12 pounds a year, so which was really good. And the other thing I'd like to point out too is the cost in this block. And I have average wholesale price. So average wholesale price, what that just means is that is what the manufacturer is going to charge me to buy that. So as retailers to buy it. So like our retail pharmacies, that's what this price we have to pay. But you guys, probably an eye opener there, about $1,600 and $13, and that's just 1 month's supply on there. Next slide. The other one is semaglutide, and this one is sold as Wegovy, which is the anti-obesity FDA indication one. It's also sold under 2 other brand names, Ozempic and Rybelsus. Wegovy and Ozempic are injectable sub-Q dosing, and they are weekly. If you remember from the previous slide, we made some improvement. Those were daily injections. These are weekly injections. Rybelsus is oral. And side effects, again, nausea, vomiting, diarrhea, acute pancreatitis. Another side effect that's kind of been reported in this is diabetic retinopathy. And so they're kind of recommending that patients have eye tests with that. That seems to be with just the semaglutide right now. But one of the things that I'm really happy about is look at that weight loss, about 33 pounds a year. That's huge. That's awesome for our patients. The other thing, again, the cost there, over $1,000 for a month. So we'll talk a little bit more about that in a few minutes. And then here's our newest blockbuster drug that came out. And basically Mounjaro, tirzepatide. So I'm sure you guys, unless you've been living in a silo, you've heard about these medications. They're all over social media, the national news. And in October of 2022, because of the studies for Mounjaro in diabetes patients, they did a fast track for obesity. So probably the end of this quarter, we will probably see that it'll be granted the obesity indication for Mounjaro. And it is just like the previous, the semaglutide or the Wegovy. It is 15 milligrams is the max dose. It is a week. And something I should say with all of these drugs is you want to start slow and you want to titrate up. They all have similar side effects. They all have the vomiting, the diarrhea, the acute pancreatitis. And so ways to kind of decrease those side effects is start low, go slow, and increase up. But the weight pounds in this one is about 40 pounds per year. There is a current study going on that's looking at semaglutide or Wegovy and Mounjaro, and we'll kind of get a better idea of maybe one may be better than the other as far as how much weight loss we lose. But again, this one's about $1,200 a month there. So I just told you about these 3 great drugs, and I'm so excited about them. And Rain and I was joking, I'm like, I could be a cheerleader here for these. But is it too good to be true? So something to keep in mind: if 1.8 million Americans who had obesity were treated with a GLP-1, it would cost us about $1.7 million. And so a lot of insurances are not covering these medications yet for these patients. I know personally, my health insurance plan does not cover for these medications. I think a lot of them are kind of in the wait and see category because they just don't know if other brands will come out. There's new ones coming in the pipeline, new oral options instead of injection ones coming. What price are they going to come out? So that's kind of been a problem. But as you saw, the cost was over $1,000. So if you have a patient who is self-pay, they're going to have to be paying probably that price or a little higher than that. I do know, talking to some of my retail colleagues, that some insurances will pay it, but and patients are getting it for like $400 or $700 a month. But to me, that's still a lot of dollars per month when these patients are probably going to have to be on these medications forever. And so I think that that's really something when we're talking to our patients and letting them know that, they think, oh, great, everybody's taking this, I'm losing all this weight. But this may be something that we're not going to be able to stop, that it's going to be a forever medication with that. And that kind of holds true kind of going into that long-term data. We just don't have the long-term data. Most of these studies in these patients were done in diabetes. There are a few that have been approved for obesity, but they're still probably just a little over a year is how long they studied these patients. And so what's going to happen long-term with these patients? And I know Rain and I've talked quite a bit too, because these patients are losing excessive amount of weight. And so will they plateau or do they continue to lose that weight? We don't know. We know how much they've lost over a year. And so will there be doses that maybe we need to cut down on, that they have a maintenance dose instead of a long-term? So I think that's something more to come, and something that we just need to kind of tell our patients and make sure they know that, yeah, these are great, but we also have to keep those lifestyle. Drug alone isn't the cornerstone of therapy there. But because of this blockbuster, all these new drugs, nationwide shortages is happening. And so manufacturers haven't been able to keep up. I know I had mentioned, I talked to one of my retail colleagues, and she had said, like on Wegovy the other day, there's 5 strengths available, and she was able to get 2 of the 5. So there is a nationwide shortage on these. And so that's also a little bit of a concern, because patients with diabetes aren't able to get it. But then you also have these people who are obesity, who probably have cardiovascular risk, and they're not able to get it. And we do know, and what we've seen, if patients stop these medications, they're having the weight regain pretty rapidly is what's coming back. And so the other thing we're seeing is that you're seeing a lot of advertisement on social media for like clinics claiming they can compound this medication, or that they have this at a discounted rate. And one of the things I would kind of caution your patients, or just make them alert, is that on these compounded products, it's normally it's regulated and it's safe, but we have to remember that that unique ingredient, that semaglutide and tirzepatide, those are unique GLP-1 ingredients. And so that's only available as that branded product. So we can't guarantee what's in that compounded product is also what has been studied, that has not been studied in all those studies that showed that weight loss. Next slide, Raina. So just to kind of take some key takeaways from these anti-obesity medications is, remember that obesity is multifactorial disease. So as I mentioned, one size doesn't fit all. So we really, even when you're picking medications, you need to really make sure that you're looking at which agent is going to be the best for them. Make sure they know that it's going to be maybe a forever medication. Make sure that they can afford that medication. Make sure there's no adverse effects. Really cost, make sure, like I mentioned, they can afford it. Maybe their insurance will pay it. Hopefully in the future, we'll start seeing more insurances pay for this. I think maybe the American Medical Association making that designation on the BMI, that might help us too with some of this. But also let them know that it's lifestyle changes are still fundamental part recommendations to go along with these GLP-1s.
Great. Susan, thank you. That is awesome information. And I think it's so important as healthcare practitioners, wherever you are, whatever you're doing, to have some context and foundation about these medications, because they're obviously, as Susan said, they're not going back in the bottle. There's more of these hormone-based medications in the pipeline. And so at least having general understandings of how they work, their mechanisms, some of the challenges that your clients' members may face using them is just so important. All right, so over to me. So this GL1 explosion, no matter how you feel about these medications, their use or the growing use of them nationwide over the last year or so, you can't deny that there is a new fervor around weight loss. So, and identifying and acknowledging that is so important for us as practitioners of programming. So yes, this medication is a tool in this comprehensive approach, but it is creating exciting momentum. And for clients that I've worked with who have tried to lose weight their whole lives or have tried a dozen different things, these medications are providing hope for them. And so that is exciting. And what it's doing for us, I think, as providers, is it is bringing in a large population of folks into the weight loss market, or bringing them back in to be willing to try again, because now they have this new catalyst that they're feeling some results for and they're feeling more hopeful about. So with this new population, it poses the question for us and our organizations, are we positioned to meet the needs of these individuals? And I'm certainly not promoting the idea of just having a GLP-1 program. What we do in lifestyle management works for anybody, whether they're on a medication or not. But there may be some opportunities tied to this GLP-1 explosion and this new fervor that we can use in sort of directing referral channels and marketing approaches that we just need to kind of keep in our back pocket a little bit. And then what components of strong programming should be considered if we really want to give these folks who may or may not have access to this drug for their lifetime or for an extended period of time. I mean, we've heard of payers cutting off medication use because of the cost. So they started off, they had it for a few months, and now it's been taken away. We have all these national shortages. So we still want them to have the best resources to make this long-term health change stick. So as we look at programming, it's kind of like when your mother-in-law comes for a visit, it encourages you to clean up your house and finish some projects. I think this GLP-1 explosion and the sort of influx of interest in weight loss this year has encouraged us all to kind of look at what we're offering. Are there gaps in our service lines? Are we offering it in the most comprehensive way? Are there other ways it can be done and better? So I think if we think about it as an opportunity in that way, it'll kind of kickstart things for just reviewing what we're doing and maybe inspiring some new opportunities. So as we jump into program considerations, my colleagues across the country, we all kind of have a version of what comprehensive means when we talk about a comprehensive health and lifestyle program. One of the things, as we get into this further, I want to just sort of plant the seed. It's not just about the content in our curriculums. It's also about, are we considering ways to help people gain autonomy in their healthcare, mastery of the strategies that keep them there, and providing connection, as we know is so important in our human self-determination theory. And are our programs building self-efficacy through coaching? I think we are all at the point now where we understand that just straight education does not make behavior change stick. And so are we finding ways to build their belief that they can manage their health on their own through our programming? Okay, so typically comprehensive lifestyle approaches include a variety of things. I'm highlighting what I think are some of the key ones. Maybe your programs have parts of this, maybe they have all of it, but definitely physical activity, nutrition, stress management, sleep quality, those have become more highlighted in the last decade as far as lifestyle and importance to our health. Social connection since the pandemic has also been highlighted as an important factor for overall health. Growing evidence around mindset and as it relates to healing and health improvement have been really fascinating to me. I highlighted a resource, Dr. Aaliyah Crum from Stanford's Lifestyle Medicine Center. I really appreciate her work, and I've personally found it really helpful in program creation. Of course, limiting and avoiding risky substances, and then incorporating the medical monitoring component to see if we're actually moving the needle in our programming for these people. Are we seeing those health improvements, however that might look, A1C reduction, lipid reduction, blood pressure reduction, not just weight alone. So a few other considerations now that we've kind of got this overarching look at it would be how long should programs last? I think there's two ways to look at our programming. There are sort of foundation programs that contain great content around these lifestyle topics. And then there's a program or an offering that happens after that foundation program. So I know centers that are running 8-week programs, 12-week programs, lifestyle programs, 16 weeks, 6-month-long programs. And there's not a right or wrong to me on how long those things last. But I really believe that has to be some place for those participants to go post-foundation program to get them to a goal of some 1 year of intentional work towards their health improvement. We know lifestyle change takes time. We know they need repetitive opportunities to practice their new habits so they can be cemented. And 8 weeks isn't going to do it. 6 months isn't going to do it. Most of our best outcome data for weight loss maintenance is at a year or greater. So and as we look at programs, whether we're running them now or we're looking to start some, what are our existing referral channels? What are our potential referral channels? Does this GLP-1 fervor give us an opportunity to do some additional targeted marketing? I think we have an opportunity to work with either our own organizational retail pharmacies or retail pharmacies in our community to help establish new referral channels for them. They are the point where the patient picks up the medication, has an initial discussion, has it in their hand, and can they be partners with us on sharing information about our services with that client or with that patient. So just an opportunity to evaluate, where are we getting people from? How are they coming into our programming? And maybe there's new opportunities to partner. And then if we know we need a goal or longer, what are our strategies to extend engagement? Selling the need for time that we know professionally and our data shows us is hard to do. It is hard to sell weight loss maintenance to someone who bought weight loss. That has been across the board one of my most frustrating things. And as I talk to colleagues in programming, managers and things like that, it is so hard to keep them engaged. They're feeling better. They think they have it figured out, but we know that time is precious. So working on strategies to do that. And there's lots of ways you might incorporate, from technology to other creative ways. And I hope people are getting creative out there. But I do want to highlight that it doesn't have to be quantity. If you're worried that you're going to have to be nudging someone all the time, we're finding that lots of nudging and pestering sort of stuff to get them to do the healthy behavior doesn't really work, but quality engagement does make a difference. And then what's the mode of the program delivery? Is it face-to-face? Is it virtual? Is there a face-to-face component with other virtual services that they have access to? So there's a hybrid. Is it delivered one-on-one? Is it set in a group? And I have highlighted group because I really believe in the power of group to facilitate change. There's nothing like that community that it creates. It's the most efficient way to utilize our staff, our facilities, our space, and again, create something that is more powerful, I think, than the one-on-one experience. So that's just highlighted as my personal preference, but many of you out there have shared the power of groups in your life as well. So, and who's on our teams for these programs? Sometimes we get really narrow focused on who delivers content or engages with our program participants. We definitely know there's benefits in our fitness team being involved, our registered dietitians, our mental health practitioners. And as some of you might say, well, I don't have a mental health practitioner in my center. Well, you might not. That's so true. A lot of us don't. But is there an opportunity to offer that through telehealth as a component of the program that doesn't happen in your center. But there's our pharmacists. Many of us haven't had our pharmacists in the team directly, but now maybe with these new drugs coming to the market, we need to have them on board. Health coaches, nurses, primary care providers, massage therapists, even physical therapists. And I don't want us to forget about our employee assistance programs. These are incredibly underutilized. Sometimes we are the source for employee assistance programs for our organizations, but sometimes I found in many healthcare systems or settings, they're farming out that, or in employers in general, are farming it out to other services, and we're not able to take advantage of it, and our participants don't know about it as well. And then my last little tidbit about the GLP-1s specifically, because they're not going away, I think it's really, really beneficial to do some general education and provide some context to your team members who will be working directly with those people who might be on it. Are they your fitness staff, your dietitians, your health coaches? Because there are things that they may see them more frequently than the client sees their physician. So if they're hearing complaints about extra reflux, or they've eaten something before the training session and now they're having terrible reflux and they're uncomfortable, or they're getting nauseated, these are things that your team members should be aware of so they can redirect them to their primary care docs. But general information is so helpful, I think, for all of us who are in the sort of that direct patient care, so that we can be a resource for those who are using these medications. All right. So why medical fitness, and why do I think comprehensive programming is so key and so beneficial in these settings? And I know it's been so exciting to see how we define medical fitness sort of evolve over the last several years. So whether you're sitting today inside a medical fitness facility that is part of a larger healthcare system, or if you are a commercial fitness center that is hiring more credentialed and clinically based team members so that you can deliver more clinical programming, that's great. Or maybe you're a hybrid of those things where you are a commercial facility, but you're working alongside a healthcare system. And maybe, there's people all sort of mixed into that spectrum. But medical fitness still is such a great place to create a health home for participants who are working on weight loss, particularly in health improvement. We need that connection, especially doing tough things like lifestyle change, and particularly in a post-pandemic world. If they have a center, a place, it's not a scary doctor's office, it's not a scary hospital setting, but it's a place of health and support. It's so powerful. We also have in this setting so many health specialties under one roof. So we have this resource bank for our people. And these are highly qualified, credentialed team members. So we're bringing the best of the best to our people to deal with this incredibly complicated disease process. And that is so beneficial as well. And these centers are connecting to the medical community at large, whether within their own healthcare systems or just in their own collaborations. And that also adds another layer of support for our members. And the cool thing about being in these medical fitness settings is we are more retail minded. We are thinking concierge medicine. We're customer service focused. We can be responsive and creative in our programming. So I think we're very fortunate if you're able to work with that. And of course, we're in our community. We are a community hub for health. And so we have that community connection. And when community members trust us, they'll bring other community members to us. And we have goals around retention. I mean, when I was directly employed in medical fitness centers, one of our quarterly KPIs was all around retention. Many of you have those same KPIs. We are focused on keeping people as long and as engaged as possible, and we want to see their long-term success. So I really believe that the combination of these factors is why programming in medical fitness is so powerful. All right. So I want to kind of wrap things up. And again, I know we moved through information quickly, but I want to share with you kind of an example of how somebody may come into a weight management program that is comprehensive, that really tries to meet and engage them for extended periods of time. Now, I have perfect world example with a winky face on purpose, because there is no such thing as a perfect world. But I would just encourage you to kind of open up your minds a little bit, because there will be a tendency as I put something up for you, especially, I mean, I know we have incredibly successful long-term program managers out there. So your mind might go, oh, we could never do that. Oh, we tried that and that didn't work. Oh, we couldn't get that through administration. Remember, in this perfect world example, anything's on the table. I just hope it'll just inspire you to think outside of the box a little bit. And obviously knowing that there will be challenges for each of us as we work through programming in our particular setting. So let's go ahead and get started, but let your mind go. Let your team's mind go as you work. If you're working on developing or tweaking programming, get your team members involved. The goal is to think about engaging, resource tapping, self-directed relationship building, creative and fun programming. I have beat my head on many an administrative wall over the years trying to move things through. Healthcare is incredibly siloed. And so if you haven't beat your head for a while or even beat the pavement for a while, I encourage you to look at opportunities to knock down silos, collaborate, and create some unique experience, because we really need to change some lives here. And if we can use some catalysts that are going on in our world right now to do so, it would be really exciting. All right, so here we go. So MJ is our client, our person in the community. And we'll just say MJ is a middle-aged, overweight woman who has dealt with obesity her whole life. She's tried a half a dozen or more different programs. And finally, she's at her primary care physician and she's sharing this frustration, and she's having some worsening of some healthcare issues. And her doctor has decided together that they're going to start her on Wegovy. So Wegovy is entered into her electronic medical record, and that triggers a referral to a comprehensive program at the Medical Fitness Center. Now, I should have put on our team members, your IT departments, because they can be a huge asset in developing automated ways to remove the pressure of the physician remembering to send them to your medical fitness center, in recreating templates and triggering referrals. So don't forget about your IT people, wine and dine them if you need to, because they can be wonderful resources, particularly. So the medical fitness center is triggered with MJ's information. Then MJ goes to pick up a prescription at her local pharmacy, not the pharmacy that's owned by a healthcare system, but she goes to her local pharmacy and she receives, when she gets her prescription, a rack card, what we would call a rack card, which is a marketing tool. And on this rack card, there's a QR code for program information about this medical fitness center program. And maybe when she scans that QR code, it pops up to a really cool little fun video or something that highlights the program. But it's because the medical fitness center went out and worked with the local pharmacy that information is now in her hands and has been discussed with her by the pharmacist there. So now the medical fitness team follows up with MJ. They've got the referral. They send her a pre-recorded video about the program, or maybe she comes in for a face-to-face info session or a one-on-one appointment. But however she gets the information about the details, she says yes. And in our perfect world, everybody says yes. So it's very exciting. But she comes in then, she's a yes, she comes into the medical fitness center, and it's so great to do. It's so important to do initial assessments, because all of this that we're working towards is for outcome data collection to prove the efficacy of our programming. And so it can help with evaluation and just continue for us to iterate and make things better and better. So she comes in for initial assessments. Some of them are done in person, like a fitness and a body comp, but there's also many validated assessment tools that she can complete online prior to getting there that then provide information to the team. And based on her results, she's going to go through the program, but she's going to also help design her program in this perfect world. And what do I mean by that? So let's say she's going to start the super duper lifestyle program foundation at Medical Fitness X, and it's 16 weeks for foundation. So she's going to go once a week in a group to learn about all this incredible content that we've highlighted as part of a comprehensive program. She's paying a monthly repetitive rate. MJ is using her FSA card or perhaps a health savings account for her services, for this service. And then she also gets to have, either as a value added part of her monthly fee or at a discounted rate, access to a la carte services that based on her personal assessments, she decides the priority on. So maybe in between her group sessions, she gets a few personal training sessions because she has a lot of, she's nervous about exercise and would like to work with somebody. Maybe she's identified during her assessments that her stress levels are just off the charts, which are contributing to her poor health and poor eating. So she was able to be connected through the program to virtual mental health practitioners. She might want more time with a dietitian, health coaching. Maybe she's chronic pain and loves massage, or maybe she needs to quit smoking and we can help direct her to a smoking cessation program. And I know you're all sitting there going, my POS system cannot do that. There's no way, that's too complicated. Actually, many of us don't really know all that our POS systems can do, and they can do some unique things. So keep your mind open and explore options as you think through things. But then we're going to jump forward, and now she has completed that 16-week foundation. She has got her classmates. She is finishing that up. And remember, we want MJ to get to a year with us at least. So now she's sort of transitioning through some clever engagement strategies on how she can get into an ongoing program. Now, maybe the intensity is dropping off at this time. Maybe it's now bi-weekly contact, face-to-face, or monthly contact. Maybe now it's hybrid with some face-to-face sessions and some virtual sessions. But she gets to stay connected to her fellow participants and the medical fitness team. She also, perhaps because she's gotten this far, unlocks some new services, or perhaps even some discounted rates on the a la carte services she was now introduced to in the first part of the program. Maybe now she can attend cooking classes. Maybe she has a discount at a local meal prep service company because the Medical Fitness Center has collaborated with them to offer discounts to those program participants. Maybe she has more spa service access. I know some of our medical fitness centers offer spa services. It could be a million different things. I just want you to kind of open your mind to that. But because she's completed one part of it, she gets offered an additional opportunities because she's made it that far, which could continue to support her, but again, allow her to self-direct it. Okay. So she's rocking and rolling. She's doing great. She has relationships with the medical fitness team. Her weight and health have improved. Her new lifestyle behaviors are becoming more cemented every week. She's had repeated assessments. She's seen the data. She's seen the change. She's had, she's gone through maybe a year now. And so she's been through every holiday at least once, her birthday, her anniversary, a vacation. She's been through the ups and downs of her during her journey with the support of her team. And with or without her GLP-1, even if it got cut off because of poor reimbursement, she is feeling better and healthier. Her self-efficacy is building, and she's had intentional connection for at least this 1 year period of time, however that might look as far as frequency and things like that. Her outcome data has been tracked internally by the Medical Fitness Center through like body count measurements, gym attendance, fitness improvements, but also potentially through an EMR that's looking at her lab changes, her weight shifts, her blood pressure, some medication adjustments, because we see a lot of people as they lose weight get off blood pressure medicine and lower their insulin doses, and all kinds of things happen for them. And maybe in my perfect world, the Medical Fitness Center and the EMR can actually communicate. So we have this massive MJ database that highlights all of this incredible success from participating in this comprehensive lifestyle program. I know some of you are going, but I also know some of this is existing or in process of existing. So again, very exciting things that could happen here. So MJ has been through the gamut, and yes, it was a perfect world and she had a perfect experience, but I think there's lots of opportunities to highlight creativity and reevaluating how things are being done either in your current programs or in your desire to create something that is more exciting and more engaging for the long term. All right, so I'm trying to watch our time here, and I think we're wrapping up perfectly to allow for question and answers. But I just want to sort of wrap with, first of all, thank you. Thank you for indulging us and spending time with us today and allowing us to share some of our excitement, not just about medications, because, they're not for everybody, but they are a tool, but how we can maybe use this catalyst to do better in what we do well, to continue to improve, to strive and meet the needs of our clients and members. But it will take creative thinking, out of the box thinking. Collaborating is so important. And then tracking that outcome data and listening to our clients about what they are looking for. Their own learning and experimentation is so important to their own drive towards good health. So I'm going to turn it back over to Marianne, and I think she's got some questions. If you do have something that you need to reach out to us about in the future, we're going to leave this slide up with Susan's contact information and my contact information. But thank you.
Awesome. Thank you so much. That was a lot of information. We do have a few questions. So Jacob wants to know, in some clinical settings, GLP-1 medications are being heavily recommended. Now there's some concerning news released lately regarding safety concerns and lawsuits. What would be a good response to someone who's on these meds who may have concerns?
Okay, I'll go ahead, Marianne. Jacob, thanks. Great question. And there has been a lot of publicity lately, especially in regards to the GLP-1s and some risks with pancreatitis and gallbladder disease. And I think the big thing to tell our patients is one, communication with their provider. You know, I don't have that perfect medication. I always said I'd be a millionaire if I could have that perfect medication that didn't have any side effects. So every medication we take has risk over benefits. And so I think that the patient needs to be aware of their risk with the medication, but they also have to know, like, if they are having continued nausea and vomiting, because that usually should start to go away with those patients. But if that's continuing, that's when they need to call their provider. And as you know, fitness can encourage them, like, call the provider, talk to them, let them know that you're still having this, because that's where we ahead of time, if we get ahead of these, then we can prevent some of those. But I can say too, I did some looking up on that pancreatitis, and in the research, when they did all the clinical trials with the GLP-1s, there was about 16 patients that they reported out of about 14,500. So still pretty low chances, but I think, you know, the risk is there. I always give the example to my mom's 86, and she falls a lot. And she also has a heart condition, atrial fibrillation, so she needs to be on chronic anticoagulation. But there's some controversy to that, because she falls, she's going to bleed, or do we let her have a stroke? And so I think as a family member, we encouraged her, she talked to her provider, and those two made the decision of what was going to be best for her.
Awesome. Thank you. So another question is, and everybody, as we're going through these questions, feel free to type them into the chat section, to the Q&A section, wherever you'd like to put them. We're watching both. Here's a question. How do we find out the services that an HSA, FSA can cover for patients?
Good question.
Right. Yeah. And I'm happy to address that. First of all, each employer works with their third-party administrator to decide what is covered by flexible spending accounts and health savings accounts. So it will vary. But more and more are covering things that are health related, programming costs, working with a registered dietitian, and things like that. So we're seeing more and more be able to use those flexible spending cards. And so what's interesting is many of us this fall are in the process of figuring out our new benefits for the next year, and we can designate money into those HSAs and FSAs. So if people are aware of programming, we always did a bit of a programming push, particularly to employees and things like that, so they could think ahead of, maybe I want to go ahead and designate a little flexible spending account money. I'll put off LASIK this year and really focus on my health and weight, or orthodontia, you know, my Invisalign I'll wait on, or something like that. But absolutely, it's going to vary. I would always direct my clients to check with their employer to see, but there are some great online resources too that give you a general idea about what most plans cover under the FSA, HSA benefits.
That's great. Thank you. So Nina's saying, I'd love to hear your thoughts on using body composition in the assessment of lean mass / muscle mass on AOMs to be sure you are monitoring where the weight loss is coming from.
Right. It's a great question. And it's an ongoing question in any weight loss approach. We can't stop lean muscle loss completely during the process of weight loss. There's always some of it that's going to be compromised. But one of the beautiful things of including physical activity, particularly resistance training and weight-bearing exercises, will help preserve as much lean as possible. So one of the things that we can show, or at least in our own data collection, as we assess them early, those who have been more physically active or working with our personal training team will probably show less lean muscle loss than those who have not engaged in the physical activity components of the program as much. So we can't stop it completely when we're losing weight, and then making sure from the nutrition standpoint that those dietitians are guiding them on the best protein sources and they're getting adequate protein along with resistance training. But I think it's still valuable to assess body comp. I have had a few people that it did depress them because the changes weren't as significant as they thought they should be. Excuse me. So it can be controversial, but I think it's still valuable.
Great, thank you. So our next question is kind of a three-part question. So I'll read the whole thing and then we'll go back to the first part. This is from Dan, and he asks, what impact do these drugs have on vitals? When are these drugs contraindicated? And how do these drugs impact the exercise prescription? So we'll go back to the beginning of what impact do these drugs have on vitals?
Okay, I'll start, and Raina, you chime in if you have anything. So Raina kind of did mention medical monitoring in her presentation, so I think that's important. But as far as like vitals, there has, I think plasma blood glucose is important to monitor, although these GLP-1s are not very likely to show low blood glucose or hypoglycemia. There is a risk depending on what other medications they're on. So I always think monitoring their blood glucose is important. There is important, especially if these people are working out, their heart rate. There has been some reports with these medications of having elevated heart rate. And so it is recommended if these patients or individuals still have sustained heart rate, that they may have to stop that medication with that. It's also important to check the kidney function. So looking at your serum creatinine. And the reason for this is I had mentioned that these medications cause a lot of nausea and vomiting. And so the risk to, Raina brought up a good point, making sure they're eating something before, but the part about the, we don't want them to have nausea and vomiting and then end up becoming low fluid, dehydrated, that type of thing. So I think really encouraging your clients to drink plenty of fluids is very important. That's what they're kind of seeing with the risk of the serum creatinine. So I think monitoring those are really helpful too.
Yeah, and I can just sort of chime in on the exercise prescription, certainly considerations around intensity and things like that. But one of the things I've heard from some of my fitness colleagues is participants, as they start to increase up to those maximum doses of these GLP-1s, they have an incredible amount of appetite suppression. So we've had a few folks on the fitness floor do a bonk, and some of you out in the fitness world know the bonk, you know, like they get dizzy or they go down on you. And when you talk with them, they haven't been hungry, so they haven't eaten recently before their exercise. And also because of the delayed gastric emptying with these medications, it's not as quickly available as energy. So particularly carbohydrates. So if they ate 30 minutes before they came in, it's just sitting there in their stomach. So they might even get sick during a workout session. They might feel more refluxy during a workout session, and they might feel low energy. So there is some recommendations as you work with them, if they're, depending on, again, where they are and how they're tolerating their titration, that you're encouraging them to think about the timing of their nutrition. And some of them, we really kind of avoid a lot of liquid before the exercise because of the slowed gastric emptying. It's really sloshy and uncomfortable and can reflux. So those are my only real considerations around exercise prescription outside of what Susan recommended.
Awesome. Go ahead.
Oh, Marianne, I think from your other was when these drugs are contraindicated. Is that correct? Yeah. All right, great. The contraindications for these drugs, the ACOG, which oversees pregnant populations, are recommending that if you have pregnant patients on them, that you start before they're pregnant. If they want to get pregnant, you stop them 2 months before they become pregnant is the ideal situation on them. If you have a patient who has had a history of pancreatitis, that would be a contraindication. I'd monitor patients too if they've had history of gallbladder disease. That would be another one to kind of watch for. And anybody who's had, we mentioned like thyroid tumors, definitely those would be a contraindications. Kind of looking back at my slides, the acute pancreatitis, the thyroid would be contraindications.
Yeah. And there are some concerns about those who might have a history of anorexia, even if they're doing well in recovering and now maybe struggling with weight on the other side of it. Self-restricting behaviors are a little concerning since they're already going to feel that appetite suppression from the medication as well.
Yes.
Yeah. Thank you. So we have another question. Have you seen any employers' plans requiring participation in lifestyle programming in order to have these prescriptions covered for the patient or employee?
We are seeing more and more payers require that. In fact, one of our resources I highlighted was a Becker's, if you're familiar with Becker's healthcare resource, that says there's many of them. And especially as Susan mentioned, if we expand out who qualifies and we get more drugs approved for obesity and now maybe heart and cardiac issues, it's going to continue to grow the number of people who can qualify, which would increase the cost to these payers to pay these incredible amounts of money. So they are growing in number. That one of the pre-authorization criteria to meet is they have to be enrolled in a lifestyle program. And some are putting recommended lengths of time of enrollment. And some are saying, we'll pay for it, but you have to have 2 or 3 comorbid conditions along with a lifestyle improvement program. So payers are just realizing they can't really sustain this one, like Susan gave the example, if everyone who has a diagnosis of obesity was on it, it would be like 1.8 billion. That's with a B, $billion for just 1 year. And it's not sustainable. And because many people, especially if they have issues with the drug or can't tolerate it, if they go off of it, then we've spent a lot of money to have people just regain their weight. So that whole programming component is key to the success of this sort of 2-part equation, as we called it, our 1-2 punch. We've got to have both. There's a catalyst, and then there's the skeleton, the foundation of what's going to keep things going. So absolutely, we're seeing more and more of that happen. If they're going to consider it all, it's almost becoming a requirement.
Wow, thank you. Well, I'm not seeing any more questions. I know we are coming to the top of the hour. Whoops, one more question snuck in there. So if these medications are not yet covered by insurance, are those companies choosing to take it on full cost versus a split with the employee? And what is the criteria to be prescribed?
Susan, you can maybe describe the criteria of prescription, like who qualifies. And I think the BMI chart was something you referred to.
Yeah, so they're kind of looking at that. I will say, like, some of these manufacturers too, and I did mention some of them do have like drug programs so people can access these medications, and I did put that in the reference. So some of them have coupon cards, but a lot of those coupon cards now, in like a year ago, you could get them if you had obesity. Now it's basically if you have diabetes. You may have obesity, but you have to have diabetes, and that's one of the criteria to kind of get the discount. And I know sometimes when these patients are going to the retail stores, they're asked to retail pharmacies, they're asking them, is this for obesity or is this for diabetes? And the retail stores cannot sell it to them if it's not for diabetes. And so hopefully that's going to change in the future, but that's kind of where we are. But some of the manufacturers are willing to help. I think if we start getting more criteria for like the cardiovascular and the events, they're going to throw in the, like with Wegovy getting that, I think that'll help.
Yep.
Yeah, it's still very hard to get it though. Or
Yeah.
our people are losing it. That's the kind of the sad
Yes.
part. Like they'll get to
Yes.
their max dose at 3 months, have a great 1 more month, and then their payer cuts it off.
Yes.
So they
Yeah.
need to be in a program in case that's happening. And that's
Yes.
the reality. Yeah.
or if there's shortage and they can't get it too.
Yeah,
Rena. I mean, that's the
exactly.
thing too that we're seeing a lot of is
Yes.
that patients unfortunately don't have it for a month or two. So they need to make sure they're maintaining their foundation.
Yeah.
Right. Great. Well, I'm not seeing any more questions yet. So I will say thank you so much to Susan and Raina for sharing all of your knowledge with us today. Oh, John got in a question. John is saying, since these are on and off drugs, is this just another form of yo-yo dieting?
Well, absolutely could be.
It could be.
Yeah, I mean, if these people have access and they lose access, but it's hard to predict as a prescriber of a drug. If a physician, he doesn't know if this individual's insurance will stop coverage. I think they still want to put the tools into the hands of the patients, especially those who have been struggling a long time. We're hoping that the access to these medications for them are consistent, so they don't go through some of that yo-yo. But you can, although it's unlikely, there are people that, even on a medication, and as Susan mentioned, will end up probably, my prediction, and Susan and our prediction, is that in a few years, we're going to find out when people hit kind of a goal weight, they're going to be titrated back down to maybe a maintenance dose. But I think it is considered, John, a lifetime medication for a chronic disease, just like a blood pressure pill. But you might be able, like in our blood pressure example, exercise, healthy eating, the DASH diet, all those things may allow you to reduce the amount of blood pressure medicine you need. And we're hoping that with lifestyle change, people will be able to reduce the amount of medication in these kind of AOM drugs and be able to maintain, with the help of their new lifestyle, this lower body weight as well. But yeah, if they get taken on and off, absolutely, it's going to have the same impact on their health and their body weight as a yo-yo diet.
Wow. More need for that lifestyle intervention.
Oh my gosh,
Yes.
absolutely.
Yeah, no kidding.
Yes.
Well, listen, thank you again so much for sharing all this knowledge. We could go, this Q&A could go on forever. All attendees will receive an email with a speaker evaluation for today's webinar, and it includes a spot to indicate which CEC you would like to receive. So be sure to complete the survey. And even if you're not looking for a CEC, your feedback helps us with planning additional educational webinars and helps our speakers with their presentation skills. Now, just to let you know, our next webinar will be Thursday, September 7th, entitled Navigating the Legal Landscape, Empowering Nutrition and Health Coaches with a Comprehensive Understanding of Scope of Practice. And this will be with Kelly Smith and Kristen Santamaria. They are both corporate attorneys who co-founded a group called Dotted Lines & Co. to help nutrition and health coaches avoid those legal pitfalls. So I know we've got a lot of you on this webinar today, so this might be a good one for you as well. We've also got 2 other great webinars coming up in September, so be sure to check out the MFA website at medicalfitness.org. And while you're on the MFA website, check out our upcoming annual conference, November 1st through the 4th in Baltimore, Maryland. We've got 4 great days of knowledge and networking for you coming up. So thank you again for joining us today, and certainly to Raina and Susan for sharing their knowledge, and to Health One for sponsoring today's webinar. Thanks so much, everyone. Have a great end of your day.